Hello, welcome. Thank you for joining us. I'm Charlotte Osborne-Ford and I'm the CEO of Involve Kent. And you're joining us today for our annual general meeting and our social prescribing conference, Potential and Possibilities. This year, we're holding the event virtually, so you, our audience, will be at home, our staff, our trustees are at home, and some of our speakers are actually at home. But we're broadcasting live from our headquarters, Turkey Mill in Maidstone, and we've got some amazing tech support that have enabled us to do that as seamlessly as possible. We are recording the event, so if you need to step out for a moment or you want to watch something again or indeed share it, you'll be able to find it on YouTube and links to our website. We are able to take questions today and really hope that you will engage with the content and ask questions. If you'd like to ask questions, there is a comments function on YouTube. If you would like to write your question in the comments section, they are being checked and looked at, and they will be taken down and passed to the speakers so that they can take your questions if there is sufficient time. We've called today Potential and Possibility, and that's really in recognition of the increasing evidence of the impact and influence of our work in health. To do things differently, to work collaboratively, and to try new things to improve healthcare. When we talk about social prescribing, we mean that in its very broadest sense. We mean the community support to address the social determinants of health. All involved services share one aim, and that is to improve health in its broadest sense. And when we talk about social prescribing, we mean all of these involved services: navigation, support for carers, hospital discharge services, learning disability care coordinators. All of these involved services have that one aim, and they all work in the same way to help people identify what matters to them and to give them the tools, the support and the practical help to address those social determinants, to help people build a plan and move forward. We work to the World Health Organization definition of health, which is that health is a state of complete physical, mental and social well-being, and not merely the absence of disease or infirmity. And we actually argue for parity of esteem between clinical interventions and social interventions. And we have good reason to. More than 10 years ago, Michael Marmot's important review showed that around 70% of our health isn't determined by health services and clinical care. It's actually determined by those social determinants. And by that, he meant housing, finances, education, opportunity, and social connectedness. So we know that that's important. He went on to say in this World Health Organization report that as social beings, we need not only good material conditions, but from early childhood onwards, we need to feel valued and appreciated. We need friends, we need more sociable societies, we need to feel useful, we need to exercise a significant degree of control over meaningful work. And without these, we become more prone to depression, drug use, anxiety, hostility, and feelings of hopelessness, which all rebound on physical health. And yet, spending on prescription drugs is going up 5% a year to over 18 billion. And yet the need only grows. So a few facts for you. Healthy life expectancy is actually going down, and it's just 51 years for men in the most deprived areas of this country, going down to 51 years of healthy life expectancy. And that data is from the Office of National Statistics. The latest draft guidance from NICE shows that chronic pain affects 31% of the population, with all of the implications that has on work, on socialising and chronic quality of life. And we know from the NHS long-term plan that 30% of people in this country have a long-term health condition. 20% have a mental health condition. And that's, of course, before the crisis that we've had this year. So there is much to be done. It was 2 years ago, pretty much to the day, that I spoke at our AGM at Kenwood House. And at that AGM, I introduced our new project, which is Connect Well West Kent, which was a pilot to test social prescribing. We aimed to recruit link workers and to base them in just 5 GP surgeries to look at the social needs of patients, the social, emotional and educational and vocational and all of the non-clinical needs of patients. So that pilot started back in 2019, and since then we've expanded hugely. We're now working in 91 GP practices across Kent and Medway, and we have some really interesting data and information about what's happened. The data that you're seeing now is an evaluation of how the social prescribing work impacted on the individual patients, the people that we worked with. What we see is significant improvements. So 93% of people that we supported improved their well-being. And we measure that well-being through something called the ONS well-being measure. It's a recognised, nationally used and very robust tool. We found that on average people's well-being increased by 20%. That they had a decrease in loneliness of 36%, and actually they were more physically active. 42% of people were more physically active by on average an hour a week. And their self-reported health increased, so they actually reported a 10-point increase in their own perception of their health. But it wasn't just the data. So many of the patients that we talked to who'd been through social prescribing shared the same experience of overcoming despair, distress, physical and mental health problems. But so many of them said that what our link workers did through that intervention, through working with them over a period of time, is they brought hope. And this quote, "All these months I've been struggling and you have now given me hope." This quote is from a carer, and it's a quote that came in just last week, quite randomly, some feedback that we collected, but it's really reflective of all of the people that we work with involved, sharing that same experience, that through just having time to talk to somebody about what's going on in their life, to be given confidence and motivation, and to make use of the huge plethora of community services, community support, virtual services, to come up with a plan of how they can move forward and find the strength to address their own concerns and problems, really gives them hope. And so, just as Michael Marmot said, it's hope that is missing. Social prescribing can give people hope, and that hope can actually improve their physical health. And now what we know is that it does improve their physical health to the point that they no longer need as much NHS services and support. With that Connect Well West Kent social prescribing pilot, we were able to track NHS system usage for the patients that we supported. So we did that through close partnership working with the NHS Clinical Commissioning Group and with their business partner Optum. With the consent of patients, we were able to submit their NHS numbers, and data was analysed which showed that on average, after the first 6 months after seeing a link worker and after working up their own motivational action plan and being connected to local community groups, we saw a reduction in A&E attendances. So the people we had supported used A&E 13% less than they previously had. There was a reduction in unplanned hospital admission. There was a 12% decrease from hospital admissions. And lastly, GP appointments decreased. Now that's an interesting one because many of the patients told us that at first they saw their GP more as a result of social prescribing. And that was because social prescribing had helped them think about their health in a holistic way, and it had given them the confidence to address sometimes long-standing issues with their health. And that meant that on occasion, some patients decided they would go to their GP to have their mental health addressed or a long-standing physical concern addressed. So what we saw was GP appointments increasing a little bit at the beginning, and then as patients build those skills and that confidence to look after their health, GP appointments decreasing. What was interesting in this cohort of patients that we analysed this data is, on average, they were seeing their GP 34 times a year. Now, that's hugely more than the average person in the UK, who would see their GP on average 5 times a year. So we know that for these patients, they were very complex and they did have very serious health conditions, and yet we were able to reduce their reliance on NHS service and improve their health and their well-being. Social prescribing is recognised by the government now as being a potentially impactful and effective solution to some of these long-term health conditions and issues within society. And actually, the NHS are making the biggest investment in social prescribing by any national health system, legitimising community-based activities and support alongside medical treatment as part of personalised care. So we're seeing huge interest in social prescribing, we're seeing huge investment in social prescribing, and that's because of this growing evidence base that social prescribing works, that it's effective, and actually that it can reduce demand on the NHS. But in order to make this work, we absolutely have to think differently. There's no good in simply throwing money at the system and expecting things to be different and expecting things to change. We have to work across organisational boundaries, organisational cultures, organisational disciplines. And that's really what we wanted to bring to you today is three collaborators for Involve who come from different sectors, from the university, academic sector, from NHS commissioning, and a practicing GP and clinical director. Different parts of the health system coming together to think differently, to think creatively, and to think about the potential and possibilities that social prescribing may offer the system and our population. So on that note, I'm delighted to hand over to my colleague Laura, who is going to present the first slideshow, which is on social prescribing integrating with the NHS and the opportunities this brings. So if I could welcome Laura.
Hello everybody, thank you for that, Charlotte. My name's Laura Tilley. I'm the Lead Commissioner for Long-Term Conditions working in NHS Kent and Medway CCG, and I work within the West Kent patch, which was formerly West Kent CCG. So I'm going to start off today to talk to you about what we're doing with social prescribing in West Kent, what we mean when we say integrating services, what our approach is in West Kent in terms of integrating social prescribing with our long-term condition services. And then I'm going to give an example of our integrated pain management service and how Involve are working in partnership with this team. And then finally, I'm going to summarise with some of the early lessons learned from this work that we've done so far. So, social prescribing in West Kent. First off, this is a map of Kent and Medway. When I say I work in West Kent, it's the lovely pink section. The areas surrounding the towns of Maidstone, Tunbridge, Tunbridge Wells and Sevenoaks. In West Kent, we've got two parallel strands of social prescribers. So we have what I'm going to be talking about today, as Charlotte's already mentioned, the Connect Well West Kent link workers. This is a pilot jointly funded by the Department of Health and Social Care and the CCG. And whilst this originally started with looking at working and supporting GP practices in primary care, this is now evolving to support the changing needs of the West Kent system as a whole. So the West Kent system, the Integrated Care Partnership, has a vision. And that vision is to improve the physical, mental and social health and well-being of the West Kent population and reduce health inequalities. So you can see here how social prescribing is a perfect fit for that. Our second stream of social prescribing, I won't be talking about today, but you'll hear later. Our primary care networks, our PCNs, have link workers. These are funded by NHS England in what's called the Additional Role Reimbursement Scheme, and these support the primary care networks with their locally identified priorities. So what do we mean by integration? It's really more than just bringing people together and expecting two puzzle pieces to slot. Integrated care or joined up care is coordinated and it's for the benefit of the patient. It's about improving their experience of care. It's about coordinating the care to best meet their needs. When care is fragmented, we get a very negative impact on the patient, negative experiences of care, negative outcomes, duplication and inefficiency of the system. And if you can see in the first graphic I've got on this slide, we have what's called silos, where we have lots of teams that are there to support patients, but they're not working together, they're not collaborating to make it the best possible experience, to get the best outcomes. So to really get those outcomes, we need to collaborate. It's the key word, and I'll probably say it a lot of times in this presentation. We establish networks of clinicians, allied health professionals, managers, commissioners, anyone with an interest in that patient holistic care. We work in partnership. We work with openness and honesty, keeping the patient at the centre. And finally, it's more than just an introduction. As a commissioner, it's more important for me that my role is to introduce all of these peers together in that network, but that it's sustainable, that this is something that's got longevity and that can keep evolving the system to meet the needs of our patients. So how are we working in East Kent with social prescribing and integration? We've developed a specialist social prescribing programme. So within this, we'll have targeted, condition-specific social prescribing that's integrated with the pathways that we've got in the NHS for specialist or secondary care. Each strand of this programme will have a dedicated link worker, and they'll have specific training, expertise and networks of their own. So the aim is that that link worker will become part of the multidisciplinary team delivering that care for the patient. We have a phased implementation plan for this programme, so we're going to really learn from our experiences as we go along with the different specialties that we're working with. I think it's important that whilst no two patients are the same, no two services are the same as well, so it's important that we take this methodical approach to see what works best. The two boxes at the bottom, I will be talking about the box on the left, which are integrated approaches. So this is where link workers are part of that multidisciplinary team. We're also working to develop targeted approaches, which are far more proactive and less reactive to the situation. So, more about this programme of work. We've chosen to focus on 3 particular pathways or specialties. We want to support our patients with musculoskeletal conditions and chronic pain. Now, we already have a service called the West Kent Integrated MSK or Musculoskeletal Service, and that includes physiotherapy, orthopaedics, rheumatology and pain management. We then decided to look at diabetes with a particular focus on patients with type 2 diabetes, again working with colleagues in our West Kent Integrated Community Diabetes Service. And finally, we're looking at respiratory conditions, initially with a focus on chronic obstructive pulmonary disease, COPD, again working with our West Kent Integrated COPD Service. But I suppose the natural question is, why these conditions? Why these patients when there are so many things we could be working on? Firstly, we have existing multidisciplinary teams with these services. We have teams that have come together, co-designed, and are working, already collaborating to deliver a pathway. We've got service specifications in place that support this, that ask teams to work in this way. Unfortunately, patients also in these groups are at greater risk of COVID infection, implications as a result of contracting COVID, or feelings of isolation if they're shielding at home. So finally, it's important to say we are remaining flexible. We will adapt. We will bring on new specialties and work with other teams as the situation arises. And my final comment on that was, we're going with the willing. It's very important to start work of this transformational nature with teams that are very engaged, and certainly that's what we've seen in our approach so far. So how are we working with these teams? In the centre of this graphic, you'll see I've put system collaboration. I said I'd mention the word collaboration a lot, and I'm not counting. We start at the top where the CCG and Involve have been working together, looking at national drivers, local drivers. Where do we want to start? For all the reasons I've outlined. We then have an initial meeting with the services themselves. The frequency or the duration of that meeting could change depending on the service, depending on the conversations. We then have discussions where we adopt a quality improvement approach. We come up with change ideas. What are the suggestions? Where are the opportunities to work together? And how could we adapt this service to accommodate social prescribing? So some ideas we've had from recent meetings were discussing when would be the best opportunity in the pathway to refer a patient to a link worker. Where are the training and education opportunities with staff members to understand what the social prescribing is? We really like the idea of co-locating the link worker with those services in the clinics as they're delivering them. And we really want to support the development of patient-led peer support groups that are sustainable and will be there in our communities for patients. Once we've had these ideas, we're putting them in place. We regularly review them, and the next circle is really talking about how we'll be monitoring outcomes. This is very important. As I've said before, we're adopting a quality improvement approach with how we're working. We're looking at things such as, are we able to identify patients that are suitable correctly? Do the staff working in the services have a good working understanding of social prescribing? And how importantly, how can they engage patients and explain and get a sound understanding of what social prescribing is to get those patients' expectations right? I said we are regularly monitoring outcomes. We're doing this in very traditional ways, such as looking at activity, how many referrals have been made. But most importantly, we're looking at the impact on the patient. We're looking at their self-reported health and wellbeing scores. And they're the same scoring mechanisms that Charlotte spoke about in her presentation just now. We're also doing something new. We're looking at something called the Patient Activation Measure, or PAM, and I'll talk about that in a slide later. So, here's a brief example of the work that we're doing with Connectwell West Kent and our integrated pain management service. I thought I'd set the scene first by really giving a snapshot of the kind of patient that uses this service. Now, no two patients are the same, but I've got some ideas on this slide. Maybe the patient has sharp shooting pain in their back. They've been diagnosed by a consultant in the hospital. So they have a diagnosis and the service is helping them, supporting them to live their life with a long-term condition. Their symptoms might be made worse with stress or staying in the same position for too long, and they might improve when they're resting. They could have disrupted or unrefreshing sleep. They could be supported by their local mental health team for their existing mental health conditions. But this could all mean that they're struggling with relationships with their family or friends, or they feel isolated. They could have a loss of confidence and motivation to perform everyday tasks without a flare-up of their condition, no longer enjoying things that they used to love. They may be unable to work due to their chronic pain, and they may have limited social interactions as a result. They may be household or dependent on others for transportation, so they may feel frustrated or have a loss of independence. So for these patients, how can social prescribing link workers help? How can they work as part of the multidisciplinary team to support the patient's health and well-being? They can develop an action plan with the patient. They can support them to work towards their goals. And they can increase their independence, improve their motivation, and increase their social interactions. And these are all done through motivational interviewing, strengths-based assessments, and all the tools that the link workers have. I wanted to include a slide that talked about what the Integrated Pain Management Service was and how it works, because I feel that might set the scene very well. The IPMS, or the Integrated Pain Management Service, is delivered by Maidstone Tunbridge Wells NHS Trust and Kent Community Health Foundation Trust, KCHFT. The green part of this triangle, Tier 2, is really the area where we're focusing on, but we are venturing into the top of this triangle too. At Tier 2, we have the group pain education sessions, one-to-one consultations with multidisciplinary team members, or the opportunity to navigate or signpost to health and wellbeing services, to social prescribing, to promote self-care. At the top of the triangle, we have Tier 3, which is where you have the more intensive interventional management of patients with chronic pain, more one-to-ones consultations within the hospital setting, and also the more intensive pain management programme, the longer duration of patient education. Throughout the whole pathway, there is what's called the biopsychosocial focus. So it is already a service that focuses on holistic needs of a patient with chronic pain, understanding that no one team alone can help and support patients. It needs a team effort. So as a commissioner, when all the teams were coming together and designing this pathway, it was very important for me to enshrine this within the service specification, within the documentation for the service. We were very clear in our vision of what we wanted the integrated MSK services to be. We wanted patients to feel empowered to take control of their physical health and their mental well-being. The service aims to improve clinical health and wellbeing outcomes for patients by supporting them to self-care, be better enabled, and have realistic expectations and goals related to their needs. Now, if that's not an advert for social prescribing, I don't know what is. And our expectation is that providers will work together within the system across organisational boundaries to deliver this. When we started working with the pain management team, our feedback from the team was varied about social prescribing, but they were very enthusiastic and welcomed this support. Some had heard of social prescribing, but weren't really sure if their patient was suitable. Some thought they had a patient that might benefit, but didn't know how to refer into the service. Others knew about the service, but as they weren't able to refer to it themselves, always recommended the GP did it, but never had that feedback as to how it went with the patient, or indeed whether the referral was made. And actually, the bottom right-hand corner, I heard one clinician say, I know exactly the type of patient who I can refer. I've been waiting for this service. This is going to be fantastic. So there was abundant enthusiasm for working in this way. So when we got together, what did we do? What change ideas did we have? We had 4 main ideas that we were working through with the pain team. First 2 were about referrals. At what point is the best time to promote a referral to link worker within the pain management pathway? We looked at the community element delivered by KCHFT, the pain education sessions, the one-to-one sessions. We then looked and spoke to someone in secondary care, one of our consultants, and looked for opportunities within outpatients to make a referral into the service. As I said before, we're very keen to get co-location of the link workers in pain education sessions and pain management programme sessions to co-deliver the message and be there to take the full advantage of the opportunities of meeting the patients directly. Also, something I'm particularly excited about is the development of patient-led peer support groups in our local communities, and this has just started in Maidstone. Early challenges we've had with this piece of work. It's very important that those talking about social prescribing have a good working knowledge of what it is and what it involves. And also support as to how to initiate that conversation with patients, and more on that slide later. Also, our plans for co-location have unfortunately been limited due to social distancing during coronavirus, but we are keeping that on our project plan, so as soon as we're able to start face-to-face sessions again, that'll be part of the way we deliver the care. And also, a really interesting point of learning, a lot of patients with chronic pain may have preferred times of day when they like to be contacted. So this is now part of the referral to the link worker. Please contact a patient between the hours of 4 and 6. So actually, at this point, it's at the patient is at the best to get the best out of that interaction with the patient at a time that's most convenient for them. This is something that we developed with that team. It's a support information leaflet for clinicians working in those integrated pathways. It's an aid memoir of who can refer, what kind of patients might be suitable, what's actually available through the social prescribing programme, and most importantly, how to initiate that conversation with the patient. I think it's not a clinical question, it's very much how do you feel about having this? Would you be willing to having this conversation with a social prescribing link worker? And I think it was something that the team asked for, that level of support. Now, this slide is something I'm particularly fond of. It's how we're measuring the outcomes of what we're doing. How are we demonstrating as we go along and at the end of this programme the impact that we've had on patients and on the system that we're working with? We want to support 200 West Kent patients with chronic pain through this work. We also want to co-locate the service with the multidisciplinary team, and we also want to support the development of the patient-led support groups. We want to see a 10% increase in wellbeing scores in the patients and a 10% increase in their self-reported health scores. We also want to see a 10% decrease in unplanned hospital admissions and A&E attendances, which reflects back on what Charlotte was saying earlier. And also an increase in their patient activation measure, their PAM scores, at 6 months by at least 10 points. I promised that I'd touch on this later in the presentation. The patient activation level are levels 1 to 4 with patients with increasing levels of activation. This is a validated licence tool that is recommended by NHS England for patients with long-term conditions. And it measures patients' skills, knowledge or their confidence to self-manage their condition. It's measured over a 6-month period, and it means that the social prescribing link worker can tailor their approach to the patient depending on what their PAM score is. There's strong evidence that patients who are supported to be more activated have an improvement in their PAM score, have better health outcomes and better experiences of care and use the system less. In diabetes, a 10-point gain in their PAM score, it means that patients are 17% less likely to be hospitalised and 18% more likely to have good glycemic control. So by way of a conclusion, what have been our early lessons learnt? The first one, and most importantly, you must never underestimate the strength of peer-to-peer collaboration. It makes me very happy as a commissioner that people don't ask for my permission to work together in this way. I make an introduction, but it's for the network of clinicians and health professionals and social prescribers, everyone involved in that patient's holistic care, to work together and have great change ideas. It's important to have openness and honesty and to break down organisational barriers. It's important to invest time to understand in how each of our respective services work. Just as no two patients are the same, no two services are the same, and there's no one size fits all. I've talked a lot about having a quality improvement approach about measuring and monitoring outcomes and changing and adapting as we go. And that's been really important, I think, in tweaking the service and making it the best we possibly can. We want to keep the focus on outcomes, on measuring and monitoring to make sure we can really see the impact on the person and the system. And finally, our services have appreciated the coordinating role of Connect Well West Kent, and I've put that almost as the gatekeepers, the entry into the voluntary and community sector with the most up-to-date and relevant list of services that can support our patients. So thank you very much, and hopefully I can come and speak to you in a year's time about how we've gone with all the other services.
Before you leave, we have some questions for Laura.
Excellent.
So the first question, as a commissioner, what are the biggest challenges of working with the voluntary sector? And I suppose in answering that, if you could reflect on working with Involve as a voluntary sector organisation, but also the wider voluntary sector.
It's a very good question, thank you. So working with Involve has been a breath of fresh air, and I think I touched on it in my last point in the early lessons learnt. So not only the services have appreciated working with Connect Well West Kent, but actually I think the commissioners have, in a sense that The voluntary sector is large and is ever changing and ever developing, and we are concentrating on the health sector, rightly or wrongly. And so it's important for us to be able to have access to the most up-to-date, relevant information about the voluntary sector. So for me personally, and I can only speak from personal experience, it's been an eye-opener and it's been a really unifying factor. I'm particularly, we talked about the impact on the voluntary sector that our pilot in West Kent has had. So I'm particularly proud of the fact that, as well as considering the impact on the patient and the impact on the system, we're also looking in a wider context at the voluntary and community sector and how an increase in social prescribers, an increase in more holistic ways of working is impacting the voluntary sector. I think that's probably something that I've never done before as a commissioner. So I think with this way of working in the last year has really opened my eyes to that, and I think it's definitely the way forward.
And we have one more question.
Thank you.
It is, can you be sure that improvements in people's social lives are relatable to their health?
It's a very good question, and I think to answer that question it would be best to have a clinician standing in here in front of you. We can only look to the evidence, we can only look to, when I spoke about the patient activation measure, it's how engaged a patient is, how confident they feel to manage their own condition. It's part of NHS England's universal personalised care approach, and there's much evidence, which unfortunately I can't quote at the moment, but there's much evidence that says that a more activated patient, a patient who feels more confident about their condition, is more able to manage their condition better, and as such will have fewer exacerbations, fewer of the flare-ups that I mentioned. And I hope that as part of this work we're doing, working with pain management, working with diabetes, working with respiratory, as part of the evidence we'll be able to collect with that piece of work as well.
Thank you.
Thank you.
Thank you, Laura, for that really informative and very clear and thorough description of that piece of work. It's really refreshing to be able to work with the NHS in that way, where boundaries are broken down and there's an equality in terms of how we work together, and a real openness to try different things and to be open-minded about working together. Our next speaker is Dr. Faye Hinsley, and Dr. Hinsley will be joining us via Zoom, so hopefully we'll be able to hand over to her. She's going to talk about another service, which is our new Children's Health and Wellbeing Navigator service. So hopefully we can hand over to Faye now.
Hello, can you hear me okay? So thank you for having me involved, and thank you for working with me over the last, only 8 months to really engineer this role and offer it as a fantastic contribution to the system in Kent and Medway. So hopefully you can see the slides. I can't on my screen, but if we could go on to the first slide, which is the vision. Really, this role came out of a sort of years of working as a GP and seeing the hardship that families have to go through while they're waiting for more support. Sometimes families don't necessarily need onward specialist support, but they do need something more than what their GP, or something more than what their school can offer them. And that's where I came to see the huge amount of need for this kind of a role, to really advocate for the patients and their families. In Kent and Medway at the moment, we have a 2 to 4 year waiting list for children, particularly for neurodevelopmental and mental health referrals from general practice. And 2 to 4 years in a primary school age child is a lifetime, really. It's hugely impacting on their education and on their family as well. So our aim was to really develop this role with the opportunity that the new PCN DES offers us. And just to go into what that is, it's a new sort of contracting arrangement with GPs, such that there are 10 different roles that NHS of England are funding for us, and they're 100% reimbursed. And one of these roles is care coordinators. So it's possible to split your patient groups into cohorts. So into, say, for example, people with dementia or people with learning disabilities, or in this case, children and young people, and really think, what are the needs for care coordination around this particular group of people at GP level? How could GPs work closely with this sort of function, this sort of role, to really help the patients and their families? And with regards to primary care and GPs, we spend a lot of our time talking to families about children. And so if we had someone who we could use in our teams, who is specifically for this role, it would be hugely helpful for our time and our workload as well. So if we go on to the next slide. Some evidence suggests that it's 40% of our workload is for children and young people. Obviously, that's variable depending on which area in which you work. I would say in my area, it's probably about 30% is about children and young people. And since COVID, it's been quite different, the type of work that we've had, and we haven't had so many people coming in because they're not able to come in so much face to face. And so we are expecting that the need out there is not yet completely quantified for what's been happening over the last 6 months. But we do know that it's during childhood when both the mental health problems start, and you can bring in some really fantastic resilience techniques and support strategies for families that could completely change outcomes for children. So going on to the next slide. Basically, the mental health problem among children and young people is escalating at the moment in a very worrying way. I've heard that in the last 6 months since COVID, we've had, and I think I'm right in saying, 2 child suicides in Kent and Medway. And this is incredibly serious. And these were both children that were on waiting lists to be seen. And I think this is an absolute tragedy. And we desperately need to improve the support for children who have been referred by GPs, but haven't yet been seen. And even for those providers that are already providing mental health services, there is only so much that they can do within their scope to be close to the patient and their family geographically, to check up on them, to really be that point of contact, to be a point of contact between the school and health. There is a great need for support at a much closer level to the patient than we've been able to provide in the past because of this mental health problem, which is escalating. So, and I mean, these figures, I'm not sure if they're completely up to date, because with COVID, we've had worsening of these figures. So it says on this slide, there's 5,038 people waiting for a caseload and 880 waiting for first assessment. I think those figures are higher, much higher at the moment. In fact, the latest I've heard is that there's 6,000 currently on the waiting list across Kent and Medway. Yeah, it's really not a good situation. We, in each PCN, we need one of these roles, really. So if we can go on to the next slide. The significant proportion of people who are on these waiting lists are waiting for an ASD, a neurodevelopmental diagnosis. And what I mean by that is either autistic spectrum diagnosis or ADHD. And the sort of providers who provide these diagnoses, they're what we call fragmented. So there's lots of different, the word has also been used, silos. There's lots of different groups that provide these services as a referral on from general practice. But they're not necessarily connected up together, and they're not necessarily closely connected to the school or to the general practice or standardised across Kent and Medway. So, and they're not really understood, these conditions either. Probably the schools have a fairly good understanding of them as they affect education, but it's not clear how they affect mental health. And it seems that they are a high there's a high comorbidity between people who have children who have ASD and ADHD, and people who have children who have severe mental health difficulties. In fact, I heard just this morning on one of my calls regarding children who needed an inpatient admission because of severe mental health reasons. So these are children that can't stay at home anymore. That the vast majority of these are autistic or have ADHD. And I think a figure I heard was that 40% of those were undiagnosed when they were admitted. So you can just imagine what the numbers are out there that we haven't even picked up on. And it's a particular type of approach that you need for autistic children and children with ADHD. It's not drugs that they need, it's not antidepressants, but it's a particular strategy to go about both parenting and teaching and also counselling. And if things are not done in that way, in that shape, in that way of talking, then the care that's provided will not work. It might as well be a waste of time. You really have to do things along the right way for a neurodevelopmental, for a person with a neurodevelopmental condition in order to have the best effect and in order to have the best outcomes. Anyway, that's all by way of introduction to the need of this role. So if we go on to the next slide. So this role, the Children's Health and Wellbeing Navigators, really puts together three of the functions that involve sort of were already working in. So the coordination of different care, which is almost more an administrative role, where you pick and choose the different parts of the system, and you're able to present them as a personalised package to the patient, or a list of things that are available, which is what the Connect Well database is for adults. It provides navigation, and that's where it's the personalised aspect. So you can choose, you can work together with your patient and their family to choose what's the right thing for them. And social prescribing, community support. I mean, these, you can see how these all interlink, but particularly with children, there's a quite niched approach to this, which will be highly in partnership with local schools and what's already being provided in local schools and the voluntary sector. Huge amount of resource available for children in the voluntary sector, which, if it was tied with the health sector, would be so impacting, which is what this role is all about, really. So going to the next slide. This service isn't time limited, so it isn't that a GP would refer one of their children into this service and then they would have a certain amount of time and then would say that's it, you know, that's the end of your treatment. This is really more that these workers work at PCN level, so they are an employee of the GP practice by virtue of the PCN contract. So they are under the governance of the GP, the clinical governance. They're like an extension, like the hands and the feet of the GP, where a GP can't do this amount of time that's needed. This person, this link, this child and wellbeing navigator is able to spend the time, recognising really that these are long-term needs, they're family needs, they're going to be affecting the siblings as well as the parents, as well as the school and the health. If there's a secondary care service which has been referred to, then it will involve that as well. So it's action focused in the sense that it's there, like social prescribing, link workers, to provide the guidance and the motivation and the help. We've got one of our patients, our families in my surgery. Mum isn't able to read and write. She was just referred to, her child, was just referred to NELF, which is the mental health provider for mental health for children. She got some forms in the post to fill in about her child, which is their standard operating procedure, as it were, but she can't read and write. So she didn't do anything with these forms. And then after a while, our wonderful children's health and wellbeing coordinator got in touch with her from research on our system, say, see, your child's been referred recently. Is everything okay? Is there anything I can do to help? She said, well, you know, I've got these forms, but I can't fill them in. So our lovely navigator got back to CAMS and said, you know, I'm really sorry you haven't received these forms. She can't read and write, but I'm going to help her with the forms. And they said, oh, it's a good thing you rang. We were just about to sign her off our system because, you know, we hadn't received the forms back. So we were about to cancel the whole thing. And that's exactly the sort of example that I find. This is the face. We all need personal support. We need an actual face to the support we receive. It's no good just receiving a service, especially when it's about something so important as your child. So it's about connecting people with a person who is under the care of their GP and the governance of their GP. So going to the next slide, the benefits. So yes, it's all about holistic care, as we've been talking about. So I've been talking about a shared care, again, as I've been talking about between these different organisations. Central point of contact, as I say, with a face. And really how this releases GPs able to do their part of it, which is to have that initial conversation with a family and then get on with the next patient in 10, as you know, GPs, we see about 35 patients a morning, or by telephone or face-to-face. And so, and the same in afternoon. So we just can't spend the time that these families really need. So it does release that time for us as well. And of course, the safeguarding is improved as well, because the more information we have about families that can be picked up, and the more we can pick up potentially dangerous situations, but in a way which is supportive. Of course, like other services in the past, but this gives us more time to really spend on these families. So yes, it puts the families able to identify the particular goals they have, the needs they have, enables that true level of personalisation, not just a word, but something that's really happening for these families. And the aim being, like most strategies for mental health for children, is to improve resilience and to improve support really for the family. So that they don't just go into those high tier settings, so that we don't end up needing to sort of put children into residential care, which is hugely upsetting for the child and for the family, but also incredibly expensive for us as a system. I can tell you that in the last year, 1920, the last fiscal year, Kent and Medway spent £32 million on residential care for 552 people. So those figures might just flow past you, but it's an incredibly enormous amount of money to spend on 552 people, and some of them are adults and some of them are children. But we need to be investing money and our support into the early interventions, things like counselling, for example. So in my PCN, we have 12 hours a week of children's counselling, which is provided by Fegans, which is another charity sector organisation. So in our PCN, we were second highest in Kent and Medway for self-harm for children in 1920. And now we're close to the bottom. And I can't say it's because of our counselling service, of course. I don't know what the determinants of that change is. But I do know that it's made a huge difference to my patients having access to counselling, 12 weeks of face-to-face counselling for my children. It's been wonderful. And how can people get in touch with those amazing charity sector organisations that are providing such a needed service without something like a role like this, the Children and Health and Wellbeing navigator role, who can have a really good knowledge of everything that's out there and connecting the family with what they need, and then providing both the family and the school to provide that early intervention at that early time, really, so we don't need to progress down these horribly upsetting paths of drugs, admissions, or worse. So this is what it's all about. So my place. So yes, I think it's the time element really. It's the early intervention. It's the time critical nature of it. Okay, so going on to the next slide, measuring the outcomes. This is something that Involve are really good at, having done it, as you can see, with the commissioners, and worked out a strategy and a plan for the social prescribing link workers to measure the impact and to use them in different sectors of healthcare. But so developing this shared care and support plan, as personalised care plan, is key. And then just to say here, and then the plan is that we'll be able to share this with other organisations through the Kent, the KMCR, which is the shared digital care platform, which is coming soon. It was always my hope was always that this role would fit as a system support and would be an interlink for different parts of the system for children and young people. Yeah, so improvements in wellbeing, we can measure wellbeing, as has been already explained, in various different ways for children. And of course, GP feedback demonstrating our reduced workload, but improved care really for our families who are struggling with these issues every day. So that's my presentation. If you've got any questions, happy to take them. Yes. So just to say again, what are the challenges for a GP of working with the voluntary sector? And the second question, Charlotte? Okay, let's start with the first one. So the challenges for a GP working with the voluntary sector, I would say, like I've just demonstrated, we deal with each problem one by one. We don't have a lot of space in our brain for the different things that are in the system able to be supportive for our patients, and the needs are very broad, and there are very many charitable organisations. I know of one that's in Maidstone, which tries to gather together 70 children's charities working in Kent and Medway, and we just don't have the resource in primary care to be able to keep a database of that kind of referral system, or as you talk to a patient, you know, to be able to have all that information in your mind, and then to be able to say, oh, I'll refer you to this one or refer you to that one. That's a challenge. And also the governance of that. So, you know, when I refer to this organisation, has it been validated? Has it been approved for safeguarding? So that's probably my challenge, my greatest challenge. And I think I'm not alone to say that. And I can't remember the second question, sorry. Charlotte, if you could ask me what the second question was. I can't hear you at the moment.
Hello?
Are my slides showing? Thank you very much for inviting me to your AGM. My name is Lindsay Forbes. I'm Professor of Public Health at the University of Kent. And I'm here to tell you about a collaboration with Involve Kent and the university, which is called SPACE, Social Prescribing to Address Adverse Childhood Experiences. It's a very exciting project. We're seeking funding at the moment from the National Institute of Health Research and have actually been shortlisted. So we're very hopeful that this project will come to pass. So what is the SPACE project? Are we on my second slide now? Can I just check? So what is the SPACE project? Well, our vision is to boost the impact of social prescribing by injecting into it the features of trauma-informed care. I'll talk a bit about that in a minute. So what we hope to do is trauma-informed social prescribing. And what our project aims to do is to understand whether the system is ready for this. So this includes all the individuals involved, including the service users of social prescribing, but also the broader system in terms of referrals to other agencies, primary care, etc. And to try and understand what we need to do to make trauma-informed social prescribing work. And how can we measure how effective it is? Because obviously if it's public money being spent on it, we need to ensure that there is good value for money for the taxpayer. So moving on to the next slide, the key assumption of trauma-informed care is that a very high proportion of the population have been exposed to traumatic experiences in childhood and are therefore traumatized. Next slide is, what do we mean by traumatic experiences in childhood? Well, traumatic experiences can be abuse of any kind, household challenges such as domestic violence or parental poor mental health or substance misuse, neglect, emotional or physical neglect. All of these things affect a very high proportion of the population. And in the UK, it's estimated that something like 5 million adults have experienced 4 or more of these adverse experiences. Now, why does this matter? On the next slide, I set out a summary of the implications of adverse childhood experiences. And this is where the problem lies, that compared with people who've never experienced any adverse experiences in childhood, people who've experienced 4 or more have very, very much worse health. They're twice as likely to get cardiovascular disease or cancer. They're 3 times as likely to get serious lung disease. They're much more likely to have mental health problems and drug misuse problems. My next slide, I think, talks about the mechanisms for this, which we don't fully understand. It may be that there's a growing literature which shows that people who've had adverse childhood experiences have different developmental changes in their brains as a child. There may be changes in the way that the hormones work, which mean that they are permanently affected by these damages in their body. This may also lead to more damaging health behaviors. They may adopt, maybe more likely to smoke, drink, use drugs as a result. But also those changes that happen in childhood might directly affect their body, so that they are more at risk of all these diseases. So my next slide summarizes what we can do about ACEs as a society. Well, obviously, the most important thing is to prevent them happening. And then if we can't prevent all of them happening, we need to build children's resilience to them.
Yeah.
We also need to intervene early.
You're in there, no one.
At risk. But what our project is about is addressing the health of adults who've already been affected by adverse childhood experiences. So these people, there are 5 million of them, and it's really important that we address their health needs and indeed break the cycle, because people who are traumatized, have been traumatized in childhood, their children are more likely to be traumatized as well. And so we need to try and break that cycle and change the vicious cycle into a virtuous one. So what works? My next slide is about addressing those needs of those adults. Now, the problem is there's a big question mark about what works. We know that there are some effective treatments for people with established post-traumatic stress disorder. So this is the very severe end of the spectrum. But of course, most people don't get anywhere near these kind of psychological therapies that work for people with PTSD. And in fact, it's very unlikely that society would be able to afford to deliver them to everybody. And one of the key problems is that people who are traumatized often don't even know that the trauma might be the cause of their symptoms. And just recognizing it in itself may help. There is a growing evidence that it may help in itself, just recognizing that connection. And these people very often have, the sort of problems, sort of relatively low-level mental health problems. They're not in contact with acute mental health services. They're not seeing psychiatrists. They don't really need psychiatrists. They just have rather sad lives and are not coping very well. And these people, we know, are heavy users of primary care services with lots of different symptoms and lots of different problems. So going back to trauma-informed care, what is trauma-informed care? Well, trauma-informed care can be seen at a system level, at an organizational level, at a service level, and at an individual one-to-one clinical level. But what it broadly speaking means is that the organization, the system, the service, it recognizes the effect of trauma on people and attempts to respond to that trauma. So that's true at all those levels. Now, obviously, if a social prescribing link worker is delivering trauma-informed care, what that means then is that the link worker recognizes the importance of trauma to the health of the people they're seeing, but then asks them sensitively about their childhood and responds appropriately in a way that builds people's resilience and prevents re-traumatization and helps them come to terms with their trauma and discover ways in which they can tackle it. My next slide summarizes why trauma-informed care hasn't been, the effects of it haven't been studied sufficiently yet. And in fact, the National Institute of Clinical Excellence recommends further research in this area. It's still quite a new concept. I mean, the idea has been around for, over a decade, but it's only really developing still into what it operationally means for a service. And it is quite difficult to build into services. It's quite commonly found currently already in the UK in youth justice services, in mental health services, but that only gets to a certain proportion of the population. But actually we want to get it to people in primary care. So the general population of whom we know where most of those 5 million people are sitting, they're not mostly in contact with mental health services or the youth justice system. But the problem is we'd love it to happen in all general practices, but the average general practice consultation is 9 minutes. They are very unlikely to have time, as well as addressing the problem that the patient has come to them with, to be able to ask about adverse childhood experiences and have time to address them sensitively in a way that can help the person. In fact, it's been tried in general practice in one big practice in the north of England, and much as all the practice staff were very supportive of the idea, thought it was really useful, they just said, we can't do this without loads of extra time in our working day, which they just didn't have. As we know, general practice is under a lot of pressure to get the patients through. There's also a need for people to be trained. Now, it doesn't take very long to be trained up in trauma-informed care, but they do need support. If you're going to train somebody in trauma-informed care, you also need to support them to make sure that they are, that their well-being is maintained. So on my next slide, I talk a bit about, I've got here, what is trauma-informed social prescribing? So what we're trying to do, we know that social prescribing is a way into trying to deliver trauma-informed care in the primary care setting. And there are many similarities between what trauma-informed care is and what social prescribing is. In other words, it's about building a safe relationship. It's conversations that happen that don't focus on immediate health problems, that focus on helping people manage their lives, focus on finding solutions to the problems of everyday life, building confidence and resilience through supporting connections into society. So we wondered, is this the answer? This is the way to introduce trauma-informed care into primary care. The other thing to note is that many of those 5 million people are the kind of people who are likely to be referred to social prescribing services. In other words, people with long-term physical and mental health issues that are in and out of their GP surgeries a lot. And we think that probably this is a good place to focus trauma-informed care. So the next slide summarizes our study. We're hoping to start in April if we can, and we've been delighted with the collaboration of Involve Kent in this. It's been a really exciting journey for us. So what we want to do is, working with Involve Kent, is first of all work out whether the social prescribing link workers that work with Involve Kent, whether they will want to be trained up, and if they are trained up, whether they feel it's helping them deliver trauma-informed care. We want to make sure that there are services for them to refer to if they need to. We want to understand what sort of problems arise in the process of social prescribing with trauma-informed care injected into it. Do we have problems with well-being of the social prescribing link workers? Do we have problems with increased levels of referrals back to the GP and subsequently to mental health services? And then ultimately we want to understand what should we be doing what should we be measuring to understand how effective it is, social prescribing with trauma-informed care. So, it's all very well measuring mental health outcomes, but that may not really hit the nail on the head of what we're trying to achieve. What we're trying to achieve is improve people's coping skills, their resilience, their ability to manage their lives, their self-efficacy, that kind of thing. So those are the sort of things that we'll be looking at in this study. And ultimately, what we want to discover is, does trauma-informed social prescribing improve the health and well-being of the people who receive it? And that's for another day, because I hope in a couple of years' time we'll be able to come back and report how successful we've been. My next slide just is an acknowledgement to our team, who've been fantastic in helping us pull together this bid. And I think that's all I was going to say. So I was wondering if there are any questions for me.
Hi, Lindsay. Can you hear me? Hi. Yes, we have got a question for you. It's a little bit challenging. How risky is it for non-clinical staff to inquire about past trauma?
Well, that's an extremely good question. And this is why we're being quite cautious about this approach. I would be very reluctant to say, it's obvious, let's just do it. Let's just start asking. But the problem is that we're taking, you say it could be risky, and we just don't know at this stage, because mostly it's been done, this sort of inquiry has mostly been studied in things like the justice system, in mental health services, where quite possibly they're a little bit more geared up to people with severe problems, and we just don't know what's going to happen when we ask people who are not at that sort of, not in crisis like that necessarily. They've just got long-term problems. How will they react? And so what we're going to do is, in the first instance, after doing some initial work to understand what people feel about doing this, we will actually ask the social prescribing link workers to do it on a very small scale. So literally 2 patients each. And then we will stop and regroup and ask the social prescribed workers and ask the patients, how was it for them? And make sure we understand about the likelihood of any adverse events. Now, the next stage, of course, is to implement it on a bigger scale, but we are going to implement a system by which we can understand if there have been any adverse events at all. But we will be vigilant about this, because it is a bit worrying. You ask people, were you ever sexually abused in childhood? Were you ever, did your mother neglect you? They might, as your question suggests, you believe, actually provoke a really quite, visceral reaction from people. So we're hyper aware of this. We have a clinical psychologist aboard who's going to work with us on this as well, so that we've got some backup of expertise. But yeah, it's an extremely good question. And as yet, we don't know, but we are going to look hard.
Thank you so much, Lindsay.
Sorry.
Thank you so much. I think if there's one thing that we could take from your slot, it was that really shocking statistic that people with adverse childhood experiences are 30 times more likely to commit suicide, which isn't one that I'd seen before, and truly shocking. Thank you very much for your contribution. We're going to let you go now. And what we are going to do is go to a very short break before we then introduce the formal business of the AGM for Involve Kent. So thank you, Lindsay, and we'll take a short break now.
Thank you very much, Charlotte. Bye-bye.
Good afternoon, everybody. My name is Stephen O'Connell and I'm the Chair of Involve Kent. And I just want to welcome everybody to our 45th Annual General Meeting. I'd like to particularly welcome our staff, volunteers, trustees, members, clients, partners and commissioners who are taking part today in our virtual AGM. And can I start by thanking Laura, Faye and Lindsay for the excellent presentations and the questions and the engagement we've had so far. Involve has a small number of company members and trustees who are eligible to approve the papers and vote for trustees today. And they are joining us by Zoom, so you will see me moving backwards and forwards between here and the Zoom. However, the entire audience is able to ask questions about any of the documents at any time. Okay, so in terms of some opening remarks, it's obviously been a very challenging year from a coronavirus point of view, particularly in the last part of the year. And I just wanted to mention that briefly, although I'm minded not to take away from the positivity of the event today. But I just wanted to acknowledge the deeply personal impact that COVID-19 will have had on many of our staff, volunteers, commissioners, partners and clients, and thank all of our frontline staff who've continued to provide vital services to those in need in these unprecedented times. And actually, as a result of the investment that we've made in IT infrastructure, we were able to implement full home working and remote services with minimal disruption. This allowed us to make 10,000 calls to 5,041 vulnerable people, welfare calls. So, again, thanking all of our managers and staff and volunteers that involve who've demonstrated their commitment to our shared values and goals in supporting our clients in such challenging times. During the year we've had a number of trustee resignations and I just wanted to mention those in particular. I just wanted to start with Richard Ash. Richard joined as a representative of Maidstone Borough Council in 2005. He was a councillor at Bearsted at the time. For many years, Richard's kept us updated with information about Maidstone Borough Council, always ensuring we were linked in. Richard also served on our finance subgroup since its inception in 2010 and applied great diligence and attention to detail. Richard brought wisdom and humility based on a lifetime of work and community experience, including his time as Mayor of Maidstone. Margaret Rose. Margaret joined the board as a trustee in 2010 and served as vice chair during 2017, at a time of considerable change and transition for Involve. Margaret's links to local agencies, including Maidstone Mediation, and her work as a magistrate brought significant additional experience to the board. Margaret was noted for her passion for volunteering, in fact over 30 years of it, in various different organisations. And she was also committed to the welfare of our staff and was closely involved in the development of our staff wellbeing policy. And finally, John Lockhurst. John is a former mental health nurse, prison governor, and now a barrister and solicitor. John used to work with Involve's V Team and Your Voice, formerly known as Platform, in 2004, and had been a trustee since 2011. And on behalf of the board, I just want to thank Richard, Margaret and John for their outstanding services to Involve, clients, staff, volunteers and board colleagues over many years, and wish them well for the future. We have a new trustee that we will, when we come to the election part of the meeting later on, in Rachel Hewitt, but we'll come to Rachel in a bit more detail at that point. So, in terms of our annual report, which hopefully you'll see on the screen now, called Healthy, Connected People and Communities in Kent. There's a couple of things that I just wanted to highlight from that report. Firstly, and it's been mentioned in the earlier presentations, but our highly successful delivery of the KCC community navigation contracts for carers and over 55s. This is 1,762 carers Involve has supported for more than 20 years, and it was great to extend across West Kent. We've also supported 1,754 older people in the first 12 months, with an 18% increase in life satisfaction. And secondly, I'd just like to mention the new primary care networks as an important new opportunity for Involve to develop social prescribing. And from our report, I'd just like to read a short story, a citation really in terms of the work of Involve. And this is called Paul's story. And 3 years ago, life couldn't get better for Paul. He owned a successful small company and worked at home with his wife. And then in Paul's words, my mother, who was in her 90s and living alone, began to experience poor mental health as a result of advancing Alzheimer's and dementia, and required a dramatic increase in her care needs. This put a big strain on the family. The logistics of her needs increased rapidly, from monthly hospital visits for her falling replaced heart valve, near blindness, and multiple advancing cancers. The trips to the mobile chiropodist, moving her GP when the Allington one closed, and complicated repeat prescriptions for over a dozen medicines. As well as all this, Paul was overseeing all the bills and jobs from running a second household. It was at this point, Paul says, he was not coping and had his first meeting at home with his wife and Involve. By this point, Paul's daughter was also very ill, being pregnant with twins, and also needed lots of help at that time. The Involved meeting changed my mother's and my life. Help was instant and comprehensive, with some of the tasks I would have found too daunting to complete being done there and then for me, plus pointers to where to access the help and financial help I needed. Things changed when the NHS-funded Bluebird carers started visiting 4 times a day to help care for my mum. Extra financial help was also available to cover my mum's extra needs. Various council bodies updated her bungalow, from panic alarms to electric chairs, to help her get up. I was able to have a holiday and respite, which my body certainly needed. When her needs moved to a point where the correct pain care was not possible at home, and a new hospital diagnosis from Pembury meant the cancers were causing her to enter end-of-life care, the hospice team helped her and me, along with district nurses and Bluebird, to move her into Abbottsley Care Centre in Staplehurst. With their care and support, her life was extended by 9 months, when we expected just weeks. Although taking Mum to Abbottsley was one of the most difficult days of my life, she thanked me a few weeks later and made a new friend, Jean, there. Mum is now sadly passed, and I am working on probate. It's difficult to express my full thanks to Involve, who saved me and my family when we had reached a point of not being able to cope with life's changes and hit hard all at the same time. The job the team do is awesome, and we can never thank them enough. We are now very proud grandparents and can look back on Mum's 96 years of life, from being a spy for the Americans in the Second World War to still making new friends in Abbottsley last year, a full and complete life. And Paul finishes by simply saying, thank you, Involve. So, at this point, in terms of the annual report, I'll ask the membership, which includes trustees, to accept the report with a proposer and a seconder, or any objectors. Thank you. We've had a proposer and a seconder. So I'll move on from the presentation of the annual report to approve the minutes of last year's annual general meeting, the 44th meeting held on the 1st of November 2019. And you should see a screenshot of that now. And again, I'll ask the membership, which includes trustees, to to approve the minutes by raising their hands or objecting?
Overwhelming support.
Thank you. Overwhelming support for approving our minutes. I'm now going to hand over to our Treasurer, Duncan Simmons, to actually present the accounts.
Good afternoon and welcome everybody. I'm Duncan, I'm the Treasurer, and what I'm here to do today is to talk you through the accounts for the year ended March 2020. These have been prepared and audited by our current auditors, ASETS. But let me show you the figures on screen, because I think the figures tell the story. This graph is the only chart that I'm going to put up on screen today, but you'll see this is a comparison of 2018, 19 and 20. And you'll see in the years 2018 and 19 that pretty much our income and expenditure were fairly static, and in each year there was a small deficit. However, in the year ended 2020, turnover has gone up 123%, and the good news is that expenditure went up by 90%. So we're delighted to confirm that this is actually the first time we've moved into an in-year surplus for a couple of years now, and this is great news for us and for our end users. Now that growth was as a consequence of three major things: the new contracts in community navigation and social prescribing, and the extension of our work through even more primary care networks. So that work that you've heard about earlier today has helped us grow to something twice the size we were a year ago. That's really important to us because a little over a year ago I remember attending a finance subgroup meeting where we were talking about in-year deficits, which is never a great thing to be talking about. And that led us on to a discussion around what sort of levels of reserves we should be holding, because reserves are important to ensure that we can continue to operate. Now it's great to see 1 year later that we've moved to a position where turnover has grown substantially. And as a banker, I'm taught that turnover is vanity, but the most important thing is cash flow. And I've brought cash flow into every conversation we've had as a finance subgroup. And the great thing is that because our turnover has exceeded expenditure, we've got reserves, and also our cash flow is positive. Reserves are healthy, and that cash flow is really important because as we get bigger, some of our contracts are with very much larger government organisations, and whilst they do eventually pay, we are at their behest sometimes, and the turnover can be a little erratic. So there have been times where we've waited probably 1 or 2 months beyond when we expected to get paid. So we're in a much better position to have healthy reserves. Reserves are also important to us because with the great work that Charlotte and the team are doing with tendering for new work for our communities, quite often our tenders have to be supported by a set of financials that show that we are robust and that we can actually build the business and have enough reserves to support the new work that we're bidding to take on. So it's great to be able to go out with new tenders with a strong set of financials. However, the most important thing for me, even though we talk finances, is that actually our strengthened financial position means we can support more people in more communities and continue to grow our strategy as an organisation. Within the finance subgroup, we always look at each activity within Involve as a separate department, and we've always ensured that they're self-funding because it's not right that some can't fund others. That's not allowed. So we did make a decision during the last trading year to end our operations in home help. This is something that's dated back many, many years and was actually now quite a relatively small part of our activity. It wasn't self-financing any longer, it was running into deficit. So we decided to end that, but with the end user always in mind, what we made sure we did was made sure that those that still wanted home help could still get home help directly from those that were actually doing it through ourselves. It was a win-win because they continue to get the support they'd always had and actually at a slightly cheaper cost. I've mentioned the finance subgroup. We meet once a month and it allows us as a group of trustees to go through with Charlotte and Gary what they're doing in terms of activities and how that's impacting the finances. And those meetings always include a very healthy discussion and challenge around what's going on and what the impacts are going to be. Charlotte and Gary are always able to ably demonstrate to us exactly what's happening, what the impact of a decision is going to be on finances, and always open to our suggestions and ideas in amending budgets, changing reforecasts, or just taking a bit more time to think about the impact of a financial of a decision on the finances. However, as a team in the finance subgroup, we never forget that our job is not to just play with the numbers. It's about what the numbers mean and the impact on our end users. So we won't make a decision just to make the numbers look pretty. The numbers are about how we can deliver. Stephen has already paid tribute to the team at Involve in his comments today, but I personally wanted to recognise Diadenia, who works in our accounts team and produces the figures for us very timely every month. There are very rarely any questions that tax me on the presentation. And on top of that, we've just managed to complete the audit of last year's figures during lockdown. An audit for a charity of this size is no small job. And Diane, supported by Charlotte and Gary, have achieved that in something that I thought would not be possible given the timescales and all the restrictions that we've had. So I want to say a big thank you to that. The financials for the year ended 31st of March were audited by ASETS, formerly known as Wilkins Kennedy, who have been our auditors for some time. Essentially, it's a clean audit, so their commentary in the finances confirm all of the activities were correct. So I'll stop now and ask if there are any questions from the audience on the actual finances. No? There are no questions, in which case we need to seek a proposer and a seconder to accept the accounts as presented and audited.
Yeah, we've got John as proposer, Richard Lester's a seconder.
Okay, thank you. We have a proposer and a seconder from the trustees, so we accept those accounts. And then we move on to the appointment of auditors, which is a standing item on our agenda. In the normal course of business, we continue to appoint the same auditors. So I just need the trustees to confirm that we are happy to appoint the current auditors for the next year.
Six trustees have raised their hands.
That sounds like unanimous agreement that we should continue to appoint the auditors. So thank you. We'll take that as appointed, which concludes my presentation on the finances. If anyone has any other questions, otherwise I will hand back to Stephen, I think. Thank you.
Okay, thank you. Thank you, Duncan. We're now going to move on to the election phase of the meeting. And the first item of business is to elect board directors by ordinary resolution. And I do have to read this out. So in accordance with Article 35, the board recommends the reappointment of the following board directors, retiring under the rotation provision of Article 32, and who offer themselves for reappointment for a further 3-year term. And there is one today, and that's Richard Lester. So if, Gary, again, if we could do a show of hands. That's unanimous. So Richard is re-elected. Thank you very much. We also have the pleasure of electing a new trustee today. And in accordance with Article 35, the board recommends the appointment of the following board directors for a 3-year term. And you will see on your slide now Rachel Hewitt, who's the Deputy Director of Strategy for NHS Kent Community Health Foundation. And Rachel has worked in operational and strategic roles in the NHS in both hospital and community services for both adults and children. She is currently Deputy Director of Strategy at Kent Community Health NHS Foundation Trust. Rachel is passionate about developing the strong links between NHS and voluntary sector organisations to better support the communities we serve. And again, I would ask for a show of hands in respect of Rachel. And that Rachel has been unanimously elected to the board. Thank you very much, Gary. In terms of, before I hand back to Charlotte for any closing remarks from today's AGM, is there any other business that has been raised, Gary?
Chance for trustees to raise their business.
Or any questions from the wider audience?
No questions.
Okay, so before we finish then, and I hand back to Charlotte for her closing remarks, and I may be in danger of possibly repeating something that Charlotte may say, but I'd just like to thank Gary and the technical team today for facilitating our first virtual AGM, our 45th AGM, but our first virtual one. And it appears to have gone rather well, actually, in terms of a virtual AGM. So thank you to the team. And finally, from me, I'd just like to thank our outstanding CEO, Charlotte, her management team, staff and volunteers involved that make us what we are in terms of our service to our clients and values. So thank you very much, and I'll hand back to Charlotte.
Thank you so much, Stephen. Yes, our first virtual AGM, and actually I hope our last, because it's so much nicer to be able to be in person and to actually see staff, trustees, our commissioners, and everybody that we do collaborate with that makes things so special and really helps us achieve what we do achieve. So I'm sure we'll always enable a virtual element, but it would be so much nicer to be here in person. And the theme we have of positivity, we really hope that will be the case. So next October or November, we're going to hire an even bigger and better venue, and we want 100 of you here, all safe, but all engaging and networking and mingling as we usually do. That said, we have had an absolutely crack team of tech experts today to help us put this together. A specialist called Chris, who has been at the helm, and I understand he spent the weekend doing some sort of event at the O2. So we are in very safe hands, as well as our usual IT team, Mark and Jay. So a huge thank you. Not only do they have a great deal of technical expertise, they're also extremely reassuring and put you at ease as a speaker to know that everything's being handled well. Just a few very quick thank yous before we wrap up. There is a cliche that no man is an island, and we've certainly seen that hugely over the last 6 months. And particularly for me personally, when lockdown started and we were suddenly working from home, everybody felt isolated. I felt isolated, and never more did I rely on my team, the executive team, but the whole staff and the trustees to make sure that we worked together, that we supported each other, and that we continued to deliver services and high quality services. And we didn't just deliver services, we also developed the innovations that we've been talking about today. So it was only in February that I first met with Dr. Hinsley to talk about the vision of a Children's Health and Wellbeing Navigator service, and 6 months in, during lockdown, we now have 12 Children's Health and Wellbeing Navigators in Kent and Medway directly supporting families. And that happened through collaboration and through trust, and actually letting go a little bit and believing in others and letting others take the lead and move forward with things. So of course I thank our speakers, Laura, Faye and Lindsay, but I also want to thank particularly Jane and Gary. Jane is our Senior Services Manager and Gary is our Deputy CEO, who absolutely we couldn't have done anything over the last year without their huge amount of commitment, expertise and support. I also want to thank, of course, our amazing staff team, a really amazing special staff team. We recruit very widely for our staff, and we advertise very widely, and we go through a really rigorous selection process. And what that means is, when I say our staff team are the very best, I'm absolutely sure they are the very best, because if we've had 100 applicants for each job, we will sift and interview and test till we get the very best people. And I don't mean that just in terms of their skills and their expertise, I mean in terms of their culture, their values, their beliefs. belief, and they all share those involved values of positivity, of excellence, of drive, of compassion, and of putting people first. And it's because of that drive in those individually and collectively that we've achieved everything that we have over the last year, including our growth and our innovation. And lastly, I really want to thank the trustees. Trustees are very much the hidden volunteers in any charitable sector. All of our trustees are entirely unremunerated. They are volunteers, they are unpaid. They are also the very skilled professional people or retired people with a vast amount of other commitments in their lives. Professional commitments, volunteering commitments, family commitments, and yet they still give their time and their energy and their commitment to involve, to help us on that journey of growth and development. And particularly, I'd like to thank our chair, Stephen O'Connell, and our vice chair, Richard Lester, who both have exceptionally demanding, busy lives, yet are still there at the end of the telephone whenever I need them, and of course, to support meetings and events like this. My last thank you is to you as an audience. Thank you for your time in joining us virtually and for listening. And what I really hope you will do is take away from this is a sense of positivity and a sense that although there are many deeply challenging, deeply worrying issues and problems, there is much suffering, much distress, but there is also potential and possibilities through collaboration, through creativity, through working together. And if you can take away something from today, it's that many of us are trying to collaborate and to make things better, and we will do so. Small steps, bigger steps, we'll keep going. Thank you for joining us today, and as I say, we are recording this, so if you'd like to watch again or share, we welcome and encourage that. Thank you very much.